So I was reminded by Professor Sir Stephen Powis in his talk about him getting older and then realised that we were both in the same class at medical school. And it reminded me of how things have changed over time and how education has changed, because when we were both undergraduates in Glasgow, we were learning in a 2-year undergraduate preclinical course followed by 3 years clinical. And during your 2 years preclinical, you had to learn huge amounts of facts. And I remember learning the branches of the facial nerve and the root of the aorta and goodness knows what. Whereas now, a medical student has one mnemonic to remember the whole of anatomy. And it's HALT, H-A-L-T, which is head, arm, leg, trunk. That's all you need. So things have changed. And another thing that's changed that was mentioned in the talk earlier by Sir Stephen was MMC. And some of you will be old enough to remember MMC. And I'm sure that those of you who are of a younger age, if you Googled MMC, what would you get now? In our age, it was modernising medical careers. If you do it now, it's the Mickey Mouse Club. So things have changed. Things have changed. So what we're going to do now is we're going to go through some more of the questions that we've kind of pertained to in the first panel meeting and discussions at the tables. But we're going to turn the emphasis away from how we deliver quality to how we deliver consistency. And Mike touched on consistency earlier. A good example of where we have difficulties with consistency is that we can have ARCPs performed across the United Kingdom, and when you break down to the regions, you find that some regions have quite considerably different outcomes from others. They may have a lot of outcome 5s, for example, because they're very pedantic and want to have every detail of the trainee's progress documented, and if one piece of information is not there, they're given an outcome 5. Other areas, you see 0 outcome 5s. So there's a lack of consistency. And we've been aware of that at Federation for a number of years. We're very keen to see that being eradicated, and we're hoping that the quality criteria will feed in to the whole process, that we can use this as a benchmarking exercise going forward, identifying good practice as well as outlining poor practice, but delivering consistency. So the questions we're going to come to, I want the tables to be doing as we've done previously. So we are continuing to go with question A in the first 2 tables. I won't walk down because it's a bit like walking down a catwalk. Table 2, or next 2 tables, questions B, next 2 tables, question C, and then all of the tables at the back, would you mind acting as question D? Because there's a lot of you down there, and you didn't get access at the last question. So I'll be coming down to you as we progress here. Once we've had our panel discussion following the feedback exercise, we'll have a new panel up, some old faces, some new faces. And then we'll be delighted to invite Professor Colin Melville to give the final speech of the day, the keynote speaker on reflections on quality from a GMC perspective, but perhaps a wider perspective of the experience that Colin's had over many years. We'll sum up at the end with reflections from Mike as the original chair for today, and as you'll be aware, we're having a reception afterwards, which we would be delighted if as many of you can stay and join us for some light refreshments and for some drinks. So the questions that we want to come to, again, I've mentioned your tables. They're on the slide here. How do we better promote the consistency of medical training? And the questions are similar to you, as you remember from the first session. How do we look at consistency across the provision of the curriculum relevant learning opportunities? How do we give consistency in terms of the formal and the informal feedback and the assessments to all of the candidates and all of the resident doctors? How do we have consistency in clinical and educational supervision? That's possibly the most difficult question here. So Group C, you may have a lot of discussion, and we'll come to that. And how do we have consistency in administrative support? And that's very relevant given what we've heard in the last week with regards to NHS England and perhaps changes in the funding structure that we're going to be seeing. And finally, Group D, the conglomeration at the top of the room, how do we have consistency and support for individual doctors?
Yeah, so there were various things which came up. The first thing which came up was that it's better now, at least for IMT, than previously, because now we have got defined minimum number of patients that people have to see, defined minimum number of clinics, and defined workplace-based assessments. But we also recognize that there is a need for ES education, because the marking of SIPs is often inconsistent between education supervisors. So it's to do with education supervisor training. And that's probably where it was, the discussion was mostly focused, because I think not many education supervisors consistently rank their trainees. And then finally we discussed that most trainees are good and good quality, so therefore you tend to get very consistent comments when you are looking at good standard trainees, but it's the problem trainees and those exceptions where you look out for. So the consistency is very much okay if your trainee is of a certain quality. What the objective of the whole exercise is to find those trainees who are not doing to an expected standard.
That's a really interesting answer. And we'll come to this at the discussion point, but of course the change in the curriculum in 2019 to IMT was to strip out the numbers, and yet you've said, oh, it's great because we've got minimum numbers now, and we wanted to move towards a holistic approach to assessment, hence the SIPs, and yet we're worried that SIPs are not being consistently reported upon. So is that an error of what we've done? Because the feedback to why we wanted to change in the first place was, it's a tick box exercise, we don't like all these numbers that we have to do. And we took cognizance of that, and now it's, maybe that's not what we're wanting to do. It's quite interesting.
So we also discussed that there is an inverse relationship between defined objectives and flexibility, because you might find a trainee who probably thinks that his training goals lie mainly in inpatients rather than outpatient clinics. But because of your minimum numbers, that flexibility is taken away from the trainee.
So just from kind of listening to the kind of discussion, one of the things that's consistently come up both here in this discussion, the prior, was about the benefit of having multiple interactions with the same consultant in order to demonstrate growth of that trainee. So that was something just that I'd listened to, that every individual in their own way, giving their own comments, has talked about having that consistency as being multiple episodes with that individual. And there's obvious implications of trying to make that happen, but trying to give that consistency at the beginning of a block in a rotational training is a challenge.
So again, coming back to I think Colin's comment earlier about apprenticeship models, and I think it has, we've heard loud and strong from the resident doctors committees that the apprenticeship model is something which is attractive. I would maybe put it to you, where would you stand, and maybe put it to the whole room, where would you stand about trainees going into IMT as a 3-year training programme in a single site? Because there's a way of delivering continuity, but would the resident doctors be happy to be allocated to a single site for a 3-year training programme? Or would they rather rotate to get varied experience? Because as we know, if your allocation is to the Outer Hebrides or to Pembrokeshire or to rural Kent, it might not be where you want to be. And everyone wants to be in London or Oxford or Cambridge or maybe Edinburgh. So where you're allocated for a continuity of time could maybe backfire on us. We've got to watch that.
Yeah. So as someone that's been plopped into Dundee for 3 years, but I would reserve direct judgment on that, because I'm aware that I am a surgical trainee, and maybe Anthony would want to fill on about the IMT perspective. But I think you do raise a good point, and I would detract from there is a notion that people want to always be an essential belt hospital, and from a couple of kind of roundtable discussions with NES actually, resident doctors, that's not necessarily the case because there's a realisation that there's some very high quality training in peripheral units.
Yeah.
Sorry.
I was just going to say that, so we routinely put our IMT trainees in the same site for 3 years, and we have had brilliant feedback. So basically people like it because it gives them consistency in where they can live and how they can commute to work. So
it may tick some of the soft elements of
exactly.
happiness, but what happens if you're allocated to a unit for 3 years and the consistency of your training is appalling? There's an issue.
Yeah.
So, we've one more comment from this table, and then we'll move on to.
So it all boils down to, as I said, if we either stick to one rotation or multiple rotation, we have to get the education supervision robust. So if you have multiple rotation, education supervisor report looking at a holistic triangulation of all evidence, and the time given needs to be utilized appropriately. And I agree that constraints with that because different sites and all that, but that continuity and having conversation with clinical supervisors and getting the feel of it and getting the triangulation is so important there. But if you stick to one site, that is easier to do, like what you're saying. But as you said, the problem is if that unit itself is not functioning well, then you have a problem there. Sure. So you have to balance it out both, and there's no right or wrong, and it's difficult to match with flexibility and getting the whole, with all this culture change with ward-based system, handover system, maybe very difficult to change what you're doing in the sense of getting to a trust level because of the funding and everything, finance and everything. But if you go down that route, the quality in those trusts need to be robustly managed. Because they have an opportunity, if they're rotating, that the 4 months, if the quality is poor also, they can somehow manage to get better quality in other institutions, and that advantage is there. But if you do the other way, so you have to balance it out and looking at the overall structure. That's my feeling. Yeah.
Super. Thank you very much. Let's move to the B question on the next two tables, if that's okay. So, consistency in terms of the assessment process, the formal and the informal assessments, and the feedback to candidates. By definition, everyone's individual. So some educational supervisors are hugely motivated and are really keen to be meeting their trainees on a regular basis, whereas others are maybe a little bit more laissez-faire. So how are you dealing with that? How are you delivering consistency in terms of the feedback and the assessment process?
Thanks. We answered the question that we thought was interesting, and so that's not to say this question isn't important.
Thanks for your vote of confidence, Alan. Thank you.
And I want to preface my comments by saying that we agreed that there is a line where inconsistency becomes unacceptable. So just remember that. And we had a really interesting conversation about what we mean by consistency. Is that the most appropriate word? Because we don't work post-training in a consistent clinical environment. So then how do we provide meaningful training experiences that embrace, understand the power of inconsistency and risk? Because that is one of the underpinning marks of clinical judgment. And we discussed how managing risk is absolutely key to this. It needs a tailored, person-centered approach. We were thoughtful that in chasing consistency, it's very tempting just to focus on what can be made consistent and lose sight of what else can be really important in the development of an individual. And we spoke briefly around the importance and the value of the generic capabilities, which some might argue are softer, but we felt they are really important to emphasize as part of that continuum of learning. And we also thought that professional satisfaction and dare I say fun can come from environments where there can be some inconsistency. So it's all ultimately consistency is about valuing people. And so I would summarize as saying that consistency is about placing, we need to be consistent in placing people at the center of care and education. So that's what we came up with, I think. Any comments, Margaret?
A very thoughtful comment to summarise it at the end. Any other comments from the two tables? We have some over here.
So we also talked about the value and benefits of delivering training, and we think we need to recognise that both for the trainer and the trainees. And providing consistent training of trainers will then help with consistency and feedback, which I don't think we have. The panel discussion earlier on talked about mandatory things, and I think that would lose trainers at the end of the day because of that. And I think we have to recognise that people do get value and joy from being a trainer. However, when you then put in mandatory or time out, we are very time pressured, and I think that will then discourage people from becoming trainers in the first place. Along with that, for consistency, I do agree there's inconsistency in our life and our job, and we have to look at that as well. However, I think having a structure, I personally, we all anecdotally have structures, but I think having a consistent structure will help with that. And also flexibility. Protected time is really important, but our jobs are messy. We can't have a fixed day a week or afternoon a week, and like other specialists have to do that, because our trainees work on rotas, and so we have to have flexibility, but definite protected time. So I think time has to be factored in that we are supposed to have, but sometimes we don't really get that.
Could I ask a question of you, which maybe it's not my role at the moment, but time is one thing. What about enthusiasm? So what about the fact that at the moment we have a model whereby we have a one-to-one relationship between a resident doctor and an educational supervisor with the support of clinical supervisors? And we know that some people are superb educators and are motivated educational supervisors and really love doing the job, and others may be less so. So in terms of consistency, are we looking at the right model of educational supervision?
Well, we did talk about not everyone has to be a trainer or wants to be a trainer. You have to be careful, I think, with that, with a kind of self-selecting group sometimes. I'm not sure. I don't know if anybody else has a thought on that.
Does anyone else want to shout out in terms of that? Rather than
I
putting you under pressure.
You definitely have to have enthusiasm, and I think if you've lost enthusiasm with being a trainer, you maybe need to reflect on that personally, and that's sometimes difficult as well.
Sorry, just wanted to add on. Enthusiasm is key for the role, and the fact that we are all here is part of the enthusiasm anyway. Otherwise, we could have been doing our own clinical work. So I think it's about instilling a little bit on the enthusiasm. They have to work. All our supervisors, education supervisors, have to kind of do that as well. And that comes from, giving time for educational supervision, giving them time for, that could be PAs, that could be giving them showing the direction, what is needed as far as the IMT trainees, as like if you are Royal College tutors, meeting the supervisors. And I've found they are very good, but obviously from the trust point of view, that time is not given, as whether it's monetary or time or whatever. Their PAs are right up to 14 PAs. They don't have time to actually meet up with them, maybe just a corridor conversation. And that is what is needed from various organizations, regulatory bodies, to actually hold the trusts into them that these are trainees and trainers, and both has to be respected for their time and value. And then the enthusiasm will definitely flow through.
And reward may not necessarily have to be pecuniary. It may well be that you get a letter from your TPD or from your DME saying, we value what you've done as an educator in the local team. Does that matter to people? I saw someone shaking their head going, that's a waste of time. But I wear a badge that says that I've got 40 years of NHS experience. I'm quite proud to wear that. If I had a badge that said, you've been a great educator from my trainee, I would be delighted to put that on and wear it. Maybe I'm an idiot, I don't know. Well, most people that know me probably think yes. But anyway, so it's not pecuniary, but I think time is important, because you cannot do this in a wing and a prayer and do it properly. So, please, sorry.
No. I think you're right about value, but it's value, isn't it? Which isn't monetary, but it's value, and feeling valued is one of the most important things. And that doesn't come from it comes from above as well, so it's a kind of not just your local area, but from elsewhere as well. So, I mean, I'm not sure I quite like a letter. I've got a badge of my 20 years, like you have, David, of your 40. So I think it's mixed, isn't it? It's dependent on the person.
Okay, we'll maybe take. Can we have a question with a hand up here, which was in this table before we move to the next one? Would that be okay if it can come to the lady with the blue?
Controversial. I think if you really value something, you have to pay for it, actually. And you're all saying you need time, but people's time is money, and it's time in job plans and things like that. So education has been fobbed off for many years as sort of like as something you can do. If you value someone and you want them to be a really good educational supervisor, you have to give them time in the job plan, and that is money. You know, it is money because you're paying them for it. But actually, the other side of that is that perhaps then we should. It also enables you a bit more to have some educational governance in the standard of supervision that they are then providing.
So the kind of recommendation is 0.25 a session per trainee. So 1 hour a week. And how many of us as educators meet with our trainees or our resident doctors 1 hour a week for a formal education session? Very few of us. But how many of us do that clinical supervision for an hour a week? I think all of us. I mean, I certainly am educating on a day-to-day basis when I'm in the acute medical unit. So it's how we value. I'm doing my education as part of my job, but I don't necessarily think that, you know, sitting down for 1 hour saying, have you filled out an MCR and I think you need to do another workplace-based assessment here is really the appropriate use of my time. So we have a model which suggests that time is required, an hour a week is required per resident doctor. I'm not personally convinced that that is the appropriate way of thinking about this. I'd rather have a motivated person that meets me on a clinical basis than sits me down in a room to go over the minutiae of an e-portfolio. But anyway, that's my personal opinion, and I suppose that's what we're here for. Let's move to the next. In fact, there is one question up the back. So can we take that?
In addition to individual supervisors providing quality from their side, it is important for the trust to recognize training as a core part of their healthcare delivery, because it's a trust. Because I don't think about the clinical level, education and training is discussed at the trust level. I think the recognition has to come from the top down. I think the trust has to recognize the trainers and the educators, not just in the form of monetary, but also in terms of giving them time and allowing that space and having some kind of a discussion at the trust level, trying to create doctors for the future. Because I'm worried we are trying to create doctors who will just be triaging doctors with no skills to do any procedures, because there is no recognition at the front door to have any safe procedure room, for example, to allow them to do procedures. We are producing doctors who are good at handing over to the next doctors to the next shift. It is important that it is being driven from the front end, and it has to start from the ground level.
Now, I'm conscious of time, and I'm probably overrunning here, so can I go to the next group for quick feedback? We'll have as rapid as we can, because we've covered a lot. So we're going on here to the administrative support and clinical supervision continuity. Comments from Group C?
So I guess the bad news is that we interpreted this in a very similar way to the people who answered point B. So we've got a lot of the same points we've made. We thought that the most important thing was trying to ensure not consistency, but that you've got consistent quality. So it's very difficult to differentiate between ensuring you've got a quality of clinical supervision and consistency. We thought uniformity was important. We thought it was important to ensure that there's good engagement. And my experience has been that you can give people the money for this, but unless you can actually free up the time in their job plan, they can't use that money and they'll take it. So there's something about ensuring people have the time and opportunity to deliver this. And there's something also about ensuring that they've got the ability to engage with the whole educational process, and that means all the educational offerings within the hospital they're working in to provide a culture. We also thought that we all recognise what makes a good clinical supervisor, but we're not sure that we're measuring it in any meaningful way, and whether there's a way that we can get some data to underline this. We thought the most important thing was to raise the floor rather than bring the good people down. We also talked briefly about consistency of administrative support, and we know there's enormous consistency of administrative support, all those of us who are involved in this. It's consistently awful everywhere, and we really had no way of knowing how to improve it beyond valuing it, and that goes back to what we've said about employing people to do it, and giving them time and giving them money.
Thank you very much. Okay, let's move to the final groups. We're up the top end here, the D question, the support for individual doctors. And I suppose the question here is about continuity, that individual doctors have the ability to raise concerns, to engage if they have particular issues with their training or whatever. So comments from the back, please.
Yeah, I suppose we didn't think just about that narrow field, but more broadly about the different groups that were involved. So not just talking about clinical supervisors and educational supervisors, but recognising the role of TPDs, DMEs, college tutors, performance support units, and considering, is there consistency of access, availability, criteria for trainees in all of these areas? And it's come down to exactly the same themes that other people have talked about there. So how you get buy-in from employers, the trusts and the boards. And I'm all for thank you letters. I write a lot of them, but I don't think they go far enough to enthuse people, and free yoga certainly doesn't do it. We talked about actually how do we make sure that there is an enforcement of allowing time, space, a positive culture, and really properly valuing, and a lot of that does come down to money, as we've already covered. I think that's very valuable. And how do we do that? So we talked a bit about carrot versus stick, and we obviously have, we're here to talk about the quality criteria for IMT, so do we have something similar to trainers? Do we have kite marking? Do we have KPIs? But all of those come with significant risk. So there's a risk that units that are trying really hard but are struggling with staffing and money then just get punished further when they're trying, and areas that are performing well because they maybe have luxury of geography or other benefits then do even better about it. So how would you make sure that that's applied in an equitable manner? So real challenges, and couldn't be applied in the same punitive manner that sometimes NTS data might be against quality criteria.
Thanks, Kerry. Kind of one final comment, and then we definitely need to get our panel together. So, Ricane just behind. Thank you.
Hi, sorry, just to add something from our table that we did particularly talk about, which is that I think we need to recognise this is all obviously happening within a very overstretched system. And so when we talk about the one-to-one relationship between the trainee and the supervisor, that's not always the experience at all. It can be very fragmented, and it can be very difficult to build those relationships, or even for the trainee to see the same patients. And so that then leads to more demand and more time actually needed by the supervisor to do that work. And so that is something that's underlying the whole issue, really.
Great, thank you. Could I ask the panel members to come to the top, if that's okay? We'll open it to the panel, and from what we've heard about consistency, the comments from the floor have been really quite vocal and perhaps quite negative. I felt that we've got problems with consistency. Maybe come to you, Jeff, first of all, since you're holding the microphone. Comments from what we've heard so far.
Okay, so just to warn you, I did make about 3 pages of notes, so if you've got a minute or so. Some really interesting discussions, aren't there? And I was very taken by 1 or 2 key points. I think we've got to be clear about what we mean about consistency, and consistency of what. And very much your quality criteria about consistency of offer, of what that educational offer is, and the educational environment. I think we're in danger of going down a consistency route in too much detail when we've got individual adult learners who will have different approaches to their adult learning, and individual adult educators who will have different approaches to the way they educate and train and measure. And so I would encourage us to think a little bit more about the individual learning needs, consistency of offer, but varying how we deliver that offer based on the individual learning needs of each individual doctor and postgraduate training and resident doctor. And Alan made the very sensible point that I think we've got to be really careful about our terminology when we're talking about consistency. What are we actually asking for with that? I think we all recognise that there's a real tension between delivering high quality education and educational supervision and the time commitment that takes when there's loads of other pressures. But again, I would come back to the fact that if we do it well, we do it in the setting of delivering clinical service. And if we get that right, then the learning experience and the experiential learning that comes out of that, I suspect, is far more powerful than the case-based discussion that happens after it. I know that's maybe a slightly controversial thing to say as an educator.
Alan, do you want to add anything? Yeah.
Oh, yeah. Thanks. So Alan Denson, Postgraduate Dean in Scotland and MRCP by examination. So yeah, I agree with what Jeff has just said. IMT is so important. It is a cog in a very complex machine. And so when I think about consistency, I would frame it in consistency across all the other cogs in that machine in how they value education, how they value those that are delivering it, so that shared commitment, so there's parity of esteem and equity of opportunity wherever you are, whatever cog you are in that system, all the way from our employer colleagues, and it was great to hear from them earlier, all the way down to our medical students and the wider multi-professional team. Thanks.
I was going to come to Anthony as one of the resident doctor committee, very experienced resident doctor committee members in London, and a point that was touched on earlier with regards kind of ownership of training and the spoon-fed nature of educational supervision. And I postulated it may be a good idea, do we really need to be having 1 hour face-to-face in a room with your resident doctor or not? And I thought you might want to comment on that.
I think I'd comment on that, that's quite a hypothetical situation to begin with. So I think you're absolutely right that different people gain their education in different ways. And I think one of the key things we talked about was the kind of need for a degree of flexibility and adaptability from both the resident and the supervisor, even whilst maintaining consistency. And I think what that really means is that what we would be advocating for is a sort of set of baseline standards that provide consistency, but allow trainees to do different things depending on their individual circumstance. This is a really important discussion from a resident point of view, because one of the most common complaints we get when people write to us on the resident doctor committee, certainly for RCP London, is about the distinctly different training experiences people have depending on which hospital or which region they're placed in. So I think addressing this is really important for people to feel like they're getting a fair crack at the training pathway that they've signed up for. I think a number of the points that were made resonated throughout the room. I think certainly one of the things that I found quite useful was Mike's slides at the start showing the data, and I think we collect a lot of data in a lot of ways, the National Training Survey, but also all the e-portfolio stuff we fill in, and I'm never sure we make the most use of that data in terms of ensuring consistency. And I think the other key point I'd talk about is about externality and the role of externality in things like the ARCP process, which has been highlighted a number of times, but also in terms of training and quality assurance of training within trusts. And I think externality is I think fairly limited a lot of the time when that QA is delivered, and I think we'd be advocating for more of that to ensure consistency, and I'd even go so far as to say there should be resident doctor involvement in some of that externality. So I think we would have a role, for example, in going to trusts where people have raised concerns and talking to the residents there, rather than it being an entirely divorced to the deanery type process. So there's a few of my thoughts on the discussion so far.
Really interesting thought at the end, and I would concur with that. I think that the people who know what constitutes good training are those who are being trained, not necessarily those who are doing the training. So I think that's absolutely correct. Now, Anita, I've not included you so far.
I'm Anita Smith, and I'm here as the Director for Hospital Specialty Training in NIMTA, so the Northern Ireland Deanery. We've taken an approach to look at inconsistencies, and we were aware that our psychiatry trainees, emergency medicine trainees had a lot of protected time within their working week. So we have implemented a change through a strategic approach with the Department of Health Strategic Group that is looking at enhancing quality of medical education. And as of last August, when our doctors rotated, each trainee has had a mandated 1 hour of self-development time. So really this is encouraging adult learners to link their learning needs through a PDP, discussions with educational supervisor, and this is for all trainees, so F1 up. And part of the observation was looking at non-training doctors working within the same trusts where 20% of their working week had protected educational time. So our aspiration is to work towards that. And so an observation coming from a medical background myself is that very few of our medical specialties had any protected educational time. Some exceptions, maybe palliative medicine. And so I suppose it's taken, the mandated nature has clearly been helpful, and we are taking feedback through our trainee forum. We've issued just a formal survey to try to work through this, and we've modified our quality management visit questions to actually ask about this. So I suppose Anthony's comment around trainees within quality management processes, we would have our adept clinical leadership, sort of out of programme experience fellows joining us on panels within the province.
It's a very interesting approach, because the self-directed learning, it's quite interesting when you speak to some resident doctors who rather flippantly say, oh, well, that's a couple of hours a week that I can't possibly take because I'm off doing clinic lists, or I'm doing endoscopy or whatever, maybe in higher training in particular. But the recommendations that have come through CopMed, I see Jeff in the CopMed side, is for 2 hours a week of self-directed learning for higher specialty trainees and 1 hour for IMTs. And yet we have no consistency in terms of delivery of that across the UK. So we perhaps need to be considering that and building that in. And certainly we have some guidance in the Federation website about self-directed learning, but we're planning to beef that up a little bit more. Now, I'm mindful that we are over time. I've not brought in Sean. I'm going to ask Sean a very distinct question here, which is about the support network that Kerry touched on out with the educational supervisor, clinical supervisor, in terms of the professional support units and so on. How can we maintain consistency there? What should we be doing? Because it's not actually intrinsically included within the quality criteria.
Yeah, so I mean, I think I agree with lots of what's been said already, in that consistency suggests there's some universal goal, holy grail, gold standard that we all should be doing, that we should always be aiming towards, and all be doing the same thing. And I think what we're really looking at is finding unacceptable variation a lot of the time, and that, and coming back to the point of externality as well. I mean, to my mind, certainly, sorry, I should have said I'm head of School of Medicine at HJW. To my mind, my externality is provided in-house almost. So we have a quality unit which triangulates feedback from health boards, from GMC survey, but also from those networks, from the Royal College tutor networks, from professional support units, trainees themselves, trainees committees. The trainees can actually email the quality unit directly, and that information is all triangulated. So I think that's a really useful way for me, and it takes a lot of work away from me directly, by providing some local externality, if you like, because the quality unit is run by a paediatrician. It's nothing to do with the School of Medicine. It's related to the whole organisation. And it provides that sort of relatively quick and easy feedback as to where there is unnecessary or unacceptable variation. But it also allows a way to look at the root cause of that. So getting back to what is causing that lack of consistency. And I think that's, there are several themes that are just consistent throughout that. That's where the consistency lies, really. And a lot of it is time and job planning and that sort of thing. So it provides that sort of externality for us.
And I suppose we also it's interesting you concentrate on the outliers, if you like, but there's also outliers at the top end who are the exemplars, and we should maybe be learning a little bit more from the exemplars. What are they doing well? It may not be because they've got lots and lots of educational and clinical supervisors. It's a big department. It may well be that they're a small department, but they just do it really well. We need to learn from that. So maybe a network that allows us to gain knowledge of what can be done across the UK at a local level, and then see that perhaps Wales are doing it differently from Scotland. Maybe we should pick up things in Scotland that you're doing in Wales, and vice versa. So an ability to learn from each other, because we all act in silos, I think, at the moment. Anyway, I'm very mindful that we've overrun, and that's my apologies, because I maybe let the questions go. Can I thank the panel for their learned input to the floor discussion?